Hi there guys, and welcome to today's live stream. We're going to be having a session on the whiteboard today all about spondylolisthesis, what they are, how they're working, the different variations of those, and also at the end of the live stream we're going to be going through some tips if you've got this, how you should approach your rehab. And then as always, we've got Lara the other side of the camera. We're going to be going through the Q&A at the end of the live stream. So if you've got your questions on this topic or anything related to back pain, then post those in the comments below because we'll address those questions as we get to the end of the live stream. If you're new to the channel, please do consider subscribing, hit the notification bell. That allows you to stay up to date when we go live. We go live every single weekday, and some exciting announcements coming tomorrow. We'll be doing our first, or starting our first, giveaway, so you'll definitely want to stay tuned for that one. That'll be tomorrow morning, I think around about 8:45. So with that being said, let's get into today's live stream. Okay, so I've got the spine here today. We're going to be talking about this spondylolisthesis, and I'm going to spend most of my time with you guys on the whiteboard today to talk through this particular topic. It's something that some people really have and don't understand. Others have a kind of idea around it, but then it raises all sorts of complications around the rehabilitation as well. So we're going to hopefully help you guys better understand it, and then understand what you can do and how you can tweak certain aspects of your rehab, understand what exercises and specific movements we should really try to avoid to make sure that we don't make things worse. So that's really, really important. We'll also talk a little bit about imaging briefly as well, just from sort of personal experience seeing patients with these sorts of things and their relationship to disc-related injuries and stenosis. So we'll get into that in a moment. First, I want to just point you out the most common area that we get these spondylolisthesis. They will also be termed on an MRI report anterolisthesis, which means it shifts forwards. They do sometimes refer to retrolistehsis, which means the vertebra shift backwards. I'm not going to get into those too much because it's all relative. Something must have then slipped forwards in order for something else to slip backwards relative to it. So we're going to focus much more on the anterolisthesis version of the spondylolisthesis. And it's a bit of a mouthful, so sorry if I'm saying that word a good number of times here today. The first thing I want to make you aware of is it generally occurs at L5-S1 or L4-5, maybe secondarily. But what we can see at the back here is we've got our spine, and obviously we know that it should have a nice smooth curve going through it, and that allows it to weight bear effectively, etc. But there will be shearing forces going from this way through, as we can see on the board here, these shearing forces that go through the spine on a daily basis. And we've got a lot of ligaments around here, etc. But the facing of these facet joints here, the way they sit against one another is like that, and that stops them going forwards. It stops the vertebra sliding forwards because of the position they're in. But under sustained stress, or maybe if there are some anomalies in the structure, this can then start to be overwhelmed and lead to spondylolisthesis. So just have that in the back of your mind when we're going through this. Now, it's also worth just touching on the fact that this can occur in the neck as well, but it's a little bit less common. It tends to be more of a degenerative in nature rather than anything more sinister when we're talking about fractures or anything like that. So when I'm talking about the degenerative form over here, if you've got this in your neck as well, then this will help you understand it a little bit more. So the good news is when they're degenerative, they tend to be a little bit more stable because it's just that slow sliding forwards over time that's leading to arthritic change. But we'll get into that later. So first thing we want to understand is the structure, the normal structure of your spine. And this is sort of my artist's interpretation of the vertebra. So we've got the bone on top, we've got the bone underneath, we've got the disc in the middle. This little circle here is the nerve, and then we've got the facets put in that position just to kind of demonstrate what they should approximately look like, and they stop that shear. Now here we're sort of representing the actual vertebra in the context of the spondylolisthesis. Now the spondylolisthesis is graded level 1 to level 4, and there's a very good chance if you're watching this video you're not level 4 or level 3, and highly unlikely that you're level 2. Most people with some degree of spondylolisthesis probably watching this video are going to be grade 1 or less. So it's important to bear that in mind. Now, grade 1 is when the top vertebra shifts forwards 1/4. Grade 2 is when it shifts forwards 1/2. So it comes over to here, so it looks something like that. and then grade 3 and 4 is 3/4 and then all the way. Over the course of time, it's very, very rare that you see anything like grade 4. I've seen a few 3.5s over the years, but generally those sorts of patients are severe trauma. You know you've done it, and something more sinister has happened. So it's highly unlikely that you've got that grade, but your MRI will detail that anyway. But the thing I want you guys to really pay attention to, because these sorts of spondylolisthesis, they're a failure of two things. Number one, they're a failure of compression. They're very, very commonly associated with a bulging disc or a disc herniation or something like that. But these injuries are a failure of that compression and shearing. And it's failure to deal with those forces simultaneously that creates the trouble. And we can then result in two forms of stenosis. The stenosis is the narrowing of the hole. So pay attention. I've highlighted the hole, so to speak, where the nerves come out here in the red, and we've highlighted it again down here in these two variations. But that space where this little nerve comes out gets affected. The other thing to bear in mind is looking top down, the spinal cord, the journey it will have to travel as well as it's coming down through here, will also potentially be affected, which is why if we don't know these things are going on, it can give you some rather peculiar symptoms from time to time. But again, the more serious variations, grade 3 and 4, are much less likely that you're suffering with those. So if we start off with the lytic or defect variation, now this is the one whereby when we're growing, when we're developing, if we go back to the original drawing here, we start off with a cartilaginous structure when we're a child and when we're developing in utero. And what happens is through our teenage years and our childhood years, these cartilage structures are turning into bone. And for whatever reason, during that developmental process, as this is developing into bone and this is developing into bone, the two areas of bone meet at a point around about here, which is called the pars interarticularis. You don't need to remember that, but it's a point around about there, somewhere in here, or just in the front here. If I draw it on here like that, you guys can see that little line just in and around there. And what's happened here is that the bone hasn't become continuous. There's a little cartilage line down there which is connecting the two islands of bone, and we know that the bone is going to be a lot stronger, and continuous bone is going to be a lot stronger than having this cartilaginous weakness point in there. And that's when you get on your MRI a pars defect or pars interarticularis defect, and that leads to vulnerability in this region here. So when we have repetitive stress, etc., on the spine over an extended period of time, especially with these shearing forces, and this is usually accompanied by sticking the bum out and being in that position too much, anterior pelvic tilt, proper anterior pelvic tilt, and we've discussed that in other videos with regards to the alignment. As we stick the bum out, we create much more shearing forces down through here. You can see how gravity is really creating a lot of shearing, driving this down through there to create a lot of pressure on these little facet joints here, as we mentioned. And if there is a weak point at this point here, it's going to allow it to shear forwards, and that is when this sort of thing starts to happen, and we get that spondylolisthesis starting to occur. Now, interestingly enough, this will quite often, in my opinion, be an incidental finding. If you've got the defect, you will have had it more or less since your middle teenage years, and it may well slowly be moving, but it creates a vulnerability. And like many of these things, patients find out them when they've injured themselves. Maybe you've done a silly movement, or some sort of fall or knock or anything like that, or repetitive strain on the area, and it's created inflammation. But then the fact that this is there becomes a barrier to recovery. It was already there before you had pain, but you've now flared it up, and now it's more difficult to deal with the underlying situation, because we've got that extra degree of vulnerability in our back, that extra degree of mobility, excess mobility in an area that we should have a good degree of stability. So that's very important. I say it's like if you had a waiter carrying lots of drinks. If they're walking around on the ground on their shoes, then if you knock them, they might be able to carry that tray and not spill any glasses. But if they're roller skating around on one leg and you knock them, all of a sudden, what looked like a very composed waiter, all the glasses go flying all over the place, and it's difficult to pick them up. So a lot of people will be managing with these, and then they have an injury that then they struggle to recover from. But the implication of that is as this vertebra slides forwards, I've drawn on here, and I haven't really drawn the disc too much, but you can already see what's happening to the space where the nerves come out of, and this is what leads to that stenosis, a changing of the bony canal. So we've got two holes that are on top of one another like that. There we go. And then that one's shifting forwards. And you can see how that small hole gets a little bit smaller, and now that creates smaller space. And when this occurs in conjunction with an injury, we get a lot of inflammation. I put inflammation and swelling down here. That's going to start to fill this space as well, excess inflammation. Plus what we normally get is a degree of bulging from the disc as well to further encroach upon this. And I'll use this opportunity to touch briefly on MRIs. This is why I really struggle with MRIs as being useful from a point of view of helping patients with rehabilitation. Because if this is a mobile spondylolisthesis, when you lie down on your back, quite often they can just bump back into place. And this normally happens with sort of grade 1/2 to 1. They might pop back into place. So you go to the MRI and they say, you've got a disc problem, we're going to do these things to help you. But then when you get a standing up x-ray, you realize, wait a second, there's something more going on here. This vertebra actually slides forwards, and now we know we've got a spondylolisthesis and something that's a little bit less stable. So we need to take that into consideration when we're recommending to you guys as patients or as people doing our rehab programs. You need to appreciate that there's a little bit more work. It's going to be a little bit of a longer process to provide stability back to this region of abnormal levels of mobility. So very, very important one, and why I really do look at standing up x-rays as being so much more useful for accurately assessing these sorts of things. The spine is a load-bearing structure. That's how it is used on a daily basis, and that's generally where it fails. It fails in load-bearing. So I've used the example before. If I was trying to look for a hole in this cup, I'm going to find it much easier when it's load-bearing with water in it than if the cup is empty. I'm not really going to find where the leak is. So that's an important one. Now, over a period of time, this one doesn't tend to affect the facets as much. If we move over to the degenerative type, this is the one where it does. So if we've got excessive forces, as we mentioned earlier, shearing at this particular segment for a long period of time, and this is the variation that tends to happen in the neck as well, then that's going to bang those facets, grind those facets for extended periods of time and wear down the cartilage surface that was separating them, like up here. And what we then start to see is this process occurring. We see a different kind of stenosis, a different picture here. Now this will normally be accompanied by a degree of disc bulging, which I haven't drawn out too much on the image here. But we also get these osteophytes starting to form around the facet joints as they compress and slide and shear forwards, and there's a bit of deformation to the bone. This variation is going to be a lot more stable in reality, but if you irritate the area, if you have a minor strain to this area, maybe we've done some gardening, or we've loaded the dishwasher and we've been knocked by the dog, for example, while we're putting a plate at the back of the dishwasher, then we can tweak some of the soft tissues around here. And if you look at the space, the red space that we compared at the very start, it's a lot smaller. So what we find with these conditions, or this state of affairs, is that the patient will maybe get what I would call a more insignificant injury, something that this guy here would just shake off and oh, I'm a bit sore for today and then I'm fine tomorrow because we heal nicely. But in this scenario, because there's such a smaller space, the small degree of inflammation that builds up that may not bother this person creates a lot more trouble in this individual here. And that's why symptoms can be more severe. Maybe we immediately get that shooting pain down the leg because it's providing significant irritation of the sciatic roots. Or maybe we get much more intense back pain as a result of this because there's just less space here. Think about your ankle. If you sprain it, how much a relatively minor ankle sprain can really swell that ankle. It's a response to a soft tissue injury. Well, that's happening, except here it's happening in an enclosed space, which is why you go to your doctor or your GP or whoever, or your chiro or osteo, maybe not the latter two, but they may prescribe you some anti-inflammatories to try and calm this down, because it's that excess inflammation that is really creating trouble here, but it's not dealing with the underlying issue. We need to figure out what exactly is going on and and do the necessary rehab. So that's pretty much it from a point of view of what is going on in the spondylolisthesis. There are a few things I really want to make you guys aware of that you really want to be avoiding if you have a spondylolisthesis, because this is really, really important. It doesn't matter to a degree which one you have, whether it's the Lytic variation or the degenerative variation or a mix of both, because sometimes you can have this on one side. Say, for example, you have it on one side here, but this side is actually normal. And what will happen is this side will slip like that and result in this side getting the degenerative form, which can create a twist through the spine. So these things can get a little bit more complicated, but we really want to be avoiding extension movements. So that's going to be that sort of movement, really pushing backwards. So those are going to be movements like the cobra. I've put yoga here because some of the movements in yoga are including the cobra, so we just want to be much more careful, I've put, when we're doing yoga exercises. And if you're someone who's part of our Back in Shape membership site and you're going through the phases, phase 1, phase 2, phase 3, I'd probably just leave that out for the time being, especially if you've got a spondylolisthesis, and I'd question, why are we doing yoga? Are we doing it for the meditation purposes? Then maybe choose something else that fits that bill. But we want to be very careful about those extension-based movements. Now, you might be thinking, I thought I'd just cover the towel first. Well, what about the towel? That's a very important question. We do want to be cautious when we're doing the towel. So what we generally recommend is, remember, we've got two issues here. We've got the shearing, but we've also got the compression, which irritates the disc. Now, when we're using the rolled up towel, the rolled up towel is large. It's a large applicator, and your knees are bent up like you guys know. You've seen the video, most likely, if you're watching this. There'll be a card somewhere around here that you can click, that side, that you can click at some point during this video, and you'll learn more about the Back in Shape program. But when we're using this towel, it's straight on the spine here, and it's not pressing on one vertebra. It's not pressing on that spondylolisthesis. It's broadly applying through the whole thing, which is going to get that gentle stretch through here and open out the disc spaces and create the decompression effect through the whole spine. It's not focused to that L5S1. It's not like it's pushing this one, pushing that forwards like that. It's not specific enough to do that. So you can rest assured that that will be okay, but I would always suggest, if you are someone who's got this condition, be it degenerative or otherwise, that you tentatively try the towel for around about 20 to 30 seconds to start with, and do that over a couple of days and slowly build it up to the 3 to 5 minutes, because most people do find it a reasonably uncomfortable to start with. And if you've done the towel and you're watching this right now, maybe you do have spondylolisthesis, then post in the comments below just to let others know that you've tried the towel and that actually it is normal to experience a bit of discomfort to start with. I know some of the guys in the membership area talk about this quite a bit in terms of the fact that it was so uncomfortable to start with, but now it's a lot better. So if you've got spondylolisthesis, do ease yourself into this particular exercise, but it can help so much with the compression, because like I said in the outset of this video, these sorts of conditions so frequently co-occur with disc injuries of some description, whether it's degenerative or whether it's lytic or the defect. The towel exercise is just so good for those, so it's really, really important. Now, when we're going forwards with the rehab, we want to decrease loading, which is why we recommend you guys the towel. We want to avoid forward bending. Anything that's further going to shear that vertebra, that's really, really important, because we ultimately want to decrease the vulnerability of your spine, but increase your general movement and mobility, not of this. That's very important. So we want to provide more support for the spine, and that's where our rehab stuff goes. That's where we're getting you doing those sensible Back in Shape protocols, where we're engaging the core. That phase 1 exercises where we're learning to re-engage the core set to provide stability to our spine. That's really, really important. We want to watch out when we're doing things like the hip flexor stretches. Those hip flexor stretches, we can arch our back too much when we do those if we're not careful, which is why we talk about it in the videos, to make sure that you guys know when you're doing that hip flexor stretch not to arch your back, especially if you've got a spondylolisthesis. And then when we move on to what we call phase 2, some of those exercises, there's going to be the risk, if you do them incorrectly, that you with a spondylolisthesis might get that happening, which we do not want. And I want to stress that this one last time, that the exercises in the Back in Shape protocol, they're built around people with these sorts of conditions, with disc injuries, with herniated discs, bulging discs, with general arthritis in the spine. And when they're done correctly, there are no problems with them. But if we don't get that proper engagement through here to provide stability and protection, particularly in this region, which is where the L5S1 is on the back. And if we don't do those correctly, if we allow our stomach to disengage when we're doing things like the dead bugs or the marching bridges or the squats or the other exercises in phase 3, if we don't keep everything engaged, then you as someone with a spondylolisthesis will be more vulnerable. It's important. None of the exercises in there are bad, and there are many exercises that are a little bit more challenging, but as long as you build them up slowly, if you've got a spondylolisthesis, take your time. Recognize that the structure, as you can see on the board quite clearly, the structure is rather different to what it should be. So it's something that you need to work with. Be very careful and focus around your technique, and that way you'll be able to rehab properly and deal with this condition effectively, because we've had numerous patients over the years, both at the Mayfair Clinic and in my experience before that, where they've had these sorts of conditions, and when they go through the process correctly, when they go through the rehab correctly, and when they relearn some of these bad movement patterns for everyday life, like gardening, like loading the dishwasher, etc., when they relearn those correctly, they will do an awful lot better in the long term. So that's a really, really important one. It's a condition that can bother a lot of people, but if we go through the rehab and understand what it is and what it means for our body, and then feel comfortable in a plan of action that we understand there are some risk factors, but we can mitigate those by doing correct technique, we're going to do very, very well. So with that, we'll go into Q&A. If you've got any questions, I'll just switch the mic over. Yep.
Brilliant. Good morning, everybody. Okay, before I deep dive into all of the questions that we've got, would you mind just running through some of the symptoms that patients with a spondylolisthesis might be feeling?
Yeah, I mean, the symptoms are going to be the same. Helps if you don't breathe in the water. The symptoms are going to be the same as any back injury. At the end of the day, it's going to be possibly some strap-like stiffness across here. Could be going into the glutes a little bit. With these sorts of issues, it's worth noting it commonly occurs at the L5S1. The TL functions very similarly. So what some people will get is a little bit of discomfort and stiffness a little bit higher up. And that's sort of compensatory more than anything else. It's not a direct consequence. We're going to get possibly some radiating pain down into the legs. If it's at L5S1, it might go into the big toe. We can get the sciatica. It can go down the back of the hamstrings. It can go all the way down the leg. It could go from one side to the other. It could swap sides. Different episodes. You may have had it for 5 years. It's been on the left-hand side, and then it's switched back over to the right-hand side. All of these different variations of back pain. Essentially, it's something that there's an injury in your lower back, and it's going to give you the symptoms associated with back pain. So back pain or sciatica. It'll be very similar as disc pain. Essentially, it's the inflammation and the compression of those nerves. That is what goes back to your brain and tells you you're in pain. It kind of doesn't really matter whether it is a specific disc bulge or whether it is a sciatica. Whether it's a disc bulge or whether it's a spondylolisthesis, both of those can result in sciatica. Both of those cannot result in sciatica. Both of those injuries could be asymptomatic for a period of time because they're not sufficient and there's not enough inflammation in that area. Both of those could swap sides, and both of those could give you a little bit of glute pain, a little bit of pain in the back of the thigh. People get a little bit too caught up on my specific pain is in the big toe. You can't treat it the same as if it's going down the back of the leg and not in the big toe, and that's not correct. And I used the example with some guys on the virtual consultation calls yesterday. If I use the example of like a cut on my hand, in fact, let's draw it out on the board. If we've got a little cut on the hand, okay, if you do a funny movement and you tear this bit of the scab here, or you tear this bit of the scab here, the pus, the inflammation, the bit of bleeding and weeping is going to happen in this region here or this region here, okay, because that's the injury. If we've got the nerve that goes down the leg there, it's going to irritate that nerve. If we've got the nerve that goes to the big toe there, it's going to irritate that nerve. Now, that injury is the same. It's no different. We don't treat it differently because the scab is picked off on this side instead of this side. We still need to treat it the same. It's the same area, but it can result in different symptoms. And I think people get caught up a little bit too much on that. We need to understand where the injury is. Your body is going to go through the natural healing process trying to heal it, but we need to work on getting proper movement so we stop picking the scab. And if we stop picking the scab, it's going to go through that normal healing process. It's going to be less scar tissue, and we're going to result with a body that is stronger, protected, and something that's healed well with minimal scar tissue. So that's quite an important one in terms of symptoms. You can get a variety of symptoms, but once we know that it's that area that's injured, that's what we need to treat.
Okay, brilliant. This is quite a detailed one this morning, so guys, please do continue with your questions because we do want to help as much as you, much of you as possible. Okay, so let's get straight to it. So Alex has said, are there any non-surgical approaches to treating osteophyte spurs and ligament thickening? He also goes on to say, if the spondylolisthesis is mobile as opposed to fused, would you be able to tell if it is mobile, and can you re-establish it into its neutral position?
So taking the last one first, you're not really going to be changing the position here. You're not going to be moving that vertebra back, etc., because fundamentally we can't really move them back, because in order to move them back you'd have to come around to the front and poke it back, so we can't really do that. As for the bony spurs, the main thing you're going to be doing from that point of view is they would go in and they sort of shave them off, but the reality is, again, it's the soft tissues that are injured that are creating that inflammation. Unless the nerve is directly rubbing and abrasing on that particular part of bony tissue, there's a very good chance, if your symptoms are fluctuating on a daily basis, maybe you have some pain now, but some pain, but the pain goes at times, then there's a very good chance it's not the bony spurs that are causing the pain, because the bony spurs are always there. The same thing with the ligamental thickening. It's commonly ligamentum flavum that thickens because it's kind of under more stress, so it hypertrophies, which means it grows, it increases in response to that stress. So if we can eliminate those stresses and reduce the level of inflammation around those structures, especially if you find that symptoms do fluctuate, maybe they go from a 5 to a 7 or a 5 to a 10, but they go back down to a 5 again, there's a very good chance that it's not necessarily the bony spurs that are the primary problem, and we can really get around those by just doing some solid rehab and stop injuring it in the short to medium term. If it's mobile, the main way you're going to find that is that the image, the alignment varies between lying down and standing up, and you can see it shift forwards. If it is a degenerative spondylolisthesis, they tend to be a lot less mobile. They tend to be a lot more rusty, so to speak. It kind of just stuck in there because it's basically the impaction of the one joint. We mentioned these facet joints here. It's the impaction of the one facet driving into the other that creates this issue here, as I mentioned when we went through the degenerative one. And that's really not going to move so much. Once you've got all those bony spurs, especially if they start to connect, it tends to get a little bit fused. And the main objective here is stop injuring the soft tissues around there so they can be as healthy as possible and as free of scar tissue as possible. But I will say that once you've got a degenerative one, you're just more vulnerable, which is why the rehab side of things is so important, why I stress that so much to you guys, because if you can stop now this getting so injured, by really strengthening up the midsection, really focusing on correct movement patterns. Some people mistakenly and instinctively, but it's wrong, tuck their bum under. So if we're tucking our bum under to try and, for whatever reason we're doing that, we're driving more pressure through the disc, so we're going to keep injuring this disc, and that's going to aggravate the underlying problem and create inflammation. So we have to be more mindful and get ourselves as close to possible to a neutral routine so that we can protect that from getting worse. I hope that's kind of answered that. If there's any clarification points, Alex, please do ask.
Okay, brilliant. So Faye's asked, good morning, my MRI says that I have a mild/moderate spondylitic degenerative change. They haven't given me a grade. The towel exercise is fine for me, but is it still fine to lay front on my arms, resting on my forehead? Is the extension too much?
Yeah, I just double check, because sometimes they might say spondylotic change or spondylolytic change. If it's spondylolytic or LYTIC, then that indicates that they're talking a little bit more about that shearing, about this one here. And I would really be a little bit more hesitant to be lying on our tummies. It is spondylolytic, yeah. If it's that, then the other one, you don't need to worry as much about it because it's something slightly different. But I probably steer clear of lying on your front for too long, because it is, especially if we've got any hip flexor tightness here, it is going to allow that bum to drop in. You might find it a little bit better to pop a pillow just underneath here, but I will stress that I try and avoid that position for extended periods, really, more than anything else. That's really the short answer, because there's other variations. Because if you start putting the pillow underneath here, which will make it more comfortable and allow that to rotate backwards, we're then going to end up with another issue, which is going to put pressure on the disc. So I don't want to give you that guidance without knowing exactly where your alignment is. I'd probably say steer clear of it and try and avoid lying on your tummy for extended periods. There's no reason you can't lie on your tummy for a few moments if it doesn't bother you, but if it bothers you for a few moments, then don't do it. And I wouldn't be doing it for sort of 30-40 minutes at a time. You are allowed to lie on your tummy, by the way. It's just not for extended periods.
Okay,
and that would be 20, 30, 40 minutes.
Okay, I'm just going to jump over to YouTube. Blossom Rose, what a nice name, has said, "Good morning. I thank you so much for your thorough explanation. Technique is so much more important than repetition.
Yeah.
So appreciate your work." So
No, it really is. The technique is so important. When we've got these or other conditions, I know some of the guys in the membership have had surgeries in the past. We get patients coming in, they've got bolts in the spine, to hold these things together. I didn't really touch on the surgical interventions for these sorts of things when they're really severe, but sometimes you get bolts basically put in. So a bolt here, and then screws that go in that hold the thing in place. But even if you've got those, or if we've got any sort of abnormal structure, the technique is just so important. But quite often, and this is the difficulty of it, if you've gone so far as to need surgery or have something like this, it's quite often there are a lot of technique inefficiencies. Even in those that are very, very active, there's small discrepancies that start to add up in the way in which we choose to move, the way in which we've learned to move, that are ineffective. And it's a case of unlearning those and relearning the correct way, and being somewhat OCD about the way in which we do these exercises to make sure that we're doing them correctly.
Okay, brilliant. I'm just going to go back to Facebook. Karen has asked, can you only get a spondylolisthesis if you have a pars defect?
No. So that would be you can get a fracture. You can literally just fracture it, but that's going to be much more traumatic. You're going to know you've done that if it's a complete fracture and you haven't had a defect there in the first place. There are a few groups in my experience that seem to be quite vulnerable to this, and they tend to be the dancing community. So it's going to be the gymnasts, the ballet dancers in particular. Those that are doing from a young age a lot of excessive backwards bending, doing things like the wheel and bridges, etc. They lend themselves to these sorts of conditions. So you just want to be very, very cautious if you're in that sort of group. I always, whenever I get a patient that comes in with more severe lower back pain and they're in their early 20s or sometimes 30s, because what happens is kind of they're either super, super flexible and strong when they're doing those activities from like 3 through to 16, 18, 20, and then they stop like completely cold turkey and don't do anything for the next 5 to 10 years, and then the back pain starts, or they kind of they stop and then it slowly comes on immediately. So those groups I always think of.
Okay, awesome. Joe on YouTube has asked, will you always have some element of pain with the spondylolisthesis, even if you do all of the right things with the rehab?
I think it's really unlikely that you'll always have some degree of pain. Very few people in existence have no pain all the time. Like there's always gonna be one, like my ankle right now is a little bit uncomfortable because I ran yesterday just on the one side. My leg is a bit uncomfortable because it's pressing against the side. But in terms of sort of severe pain where you actually tell someone I am in pain, it hurts, I'm adjusting my movement patterns for this, then there's really not the need to have it for the long term. It's just a case of where are you starting? Some people will say, well, like if I can't fix it in 6 weeks or in 3 weeks, then there's no point. Well, sometimes it's a case of undoing 30, 40 years of bad work, and that's not going to happen in a short period of time. So I would say that if you follow these sorts of protocols and do these exercises diligently and make the changes outside of the rehab environment in terms of the way in which we move, etc., we're more diligent about the way in which we use our body, there's really very little reason why these things should be persistent and be a long-term problem.
Okay, brilliant. Some more
they will be a long-term problem,
yeah,
but they won't be long-term symptomatic, if that makes sense.
Okay, some more comments and questions coming through on Facebook. So Faye has said, so even with degenerative spondylolytic change, with good core rehab, can you still be a very active person doing lots of sport, or is it the case of changing your lifestyle?
No, you've kind of hit it on the head really there. I mean, there's certain things I would want. Anything could be bad. I mean, you could be going up into the loft and fall out of the ladder, and that's not going to be good whether or not you've got a spondylolisthesis. There are certain sports that I probably wouldn't recommend. I mean, going bungee jumping, is that necessarily the best idea? Probably not. But in terms of having these sorts of changes that it was Faye, right? Faye described, there's no reason why you can't lead a normal life, but you must go through the necessary rehab beforehand. And especially maybe the younger people tend to be a little bit more impatient. Evaluate how long you've had this problem, how long it's maybe been building up or been an issue for an extended period of time, and take that into consideration when you're considering returning back to activities. And I know we discussed that yesterday on the live stream about that acronym that I made up: treat, test, rest, evaluate, action if necessary, or adjust, and then test again. We want to slowly reincorporate these activities in the future, but I definitely wouldn't be doing any of that until we've passed phase 3.
Okay, so this is super. We've got Alex Sparks saying, I do get some tingling and pain down the buttocks when I do the phase 1 core exercises for the psoas muscle. This has developed, wasn't there at the start, on the right thigh particularly. Any suggestions? I am a spondy, last known grade 1. And then Alex Vesco has replied to Alex also saying, I had this as well, Alex, but now it has gone. I imagine I've strengthened my core a little bit.
Yeah, so one thing to be really mindful of with the psoas exercise, as we're engaging that psoas, we cannot, and sometimes people do this, as they engage the psoas, they lose the core engagement. So you press down onto that leg and that happens a little bit, and that is probably where you're going wrong a little bit, Alex. Make sure you're really holding that core, so the core engagement, really nicely, and then pressing in, because if you lose it, you're going to arch your back, and that's going to irritate you and create a little bit of that tingling numbness pain. So be very mindful of that. Secondarily, if it's going a little bit sort of burny or rubby on the thigh, that can also be that you're just engaging those muscles, and the rectus femoris, one of the other muscles, is being involved and just getting a little bit tired. Be really cautious about that when you're doing the dead bugs as well, because we've got to keep that core engaged. The same thing can happen if you lose the midsection engagement. If as you engage these muscles and you slowly lower them, if that happens and the tummy sticks out, then that's going to be really bad for you. So you've got to keep it in and on as we're doing the engagement so that the spine does not move. Sometimes placing a smaller rolled up towel, just like a hand towel, just in the back here to support it and give you that mental feedback so you can feel if you're coming off the towel. That can really help you as a little aid to make sure you're doing that particular exercise correctly.
Okay, brilliant. I think that is all the questions for today.
Awesome.
Yeah. Do you want to just, if there are any more questions, maybe just pop them in now. Do you want to just let everyone who maybe isn't involved in the Back in Shape program know how to get involved, just in case they're watching this?
Yeah. If you're watching this sort of for the first time and you're not part of our Back in Shape membership, we've discussed a few bits of that today. There'll be a card either up in this corner here somewhere or just underneath, which you can click the link to that and learn a little bit more about the Back in Shape program, essentially there to take you through the appropriate rehabilitation process. But please, we get a lot of people that skip the additional information and just jump straight into the exercises. And we can tell that by some of the questions that we sometimes get asked, that people maybe have skipped some of the educational units, because back pain isn't just about an injury. It's about a number of factors that have led to that injury developing, and more importantly, that have prevented that injury from recovering, because our body heals, our body turns over. We're not the same person that we were a week or a month ago. Literally, our cells change, they divide, they replace everything, and your body is constantly trying to heal. And it's how we're using our body on a daily basis that's in some of those additional lessons that really teaches you guys the principles that are necessary to go in conjunction with those exercises. It's about you do maybe that 1 hour's worth of exercise a day. So if you're doing phase 1 or phase 2, then it'll total about an hour, maybe a touch longer than that. But there's 168 hours in a week. So how are you using the other 161 hours? And that's where those additional units of information are there to help you in those other 161 hours, because you can do the right things during your exercises. But if then we go straight back out and we're down doing stuff like this, we're going to get in trouble. So if you're interested in it, click the link underneath. If you're an existing member and maybe you can't remember some of the stuff we've spoken about in some of those videos, then please do go over there and check them out, watch those videos again, Did you have a question, Lara?
Well, just last night that we put the little tutorial on how to use the dashboard.
Yeah.
And that's the first video that you will now see when you log into the Back in Shape program.
Yeah, if you're looking at it on mobile, there's a little video now that you can just tap at the very top of the page that just shows you how to orientate yourself around the membership area to make sure you know what you're looking at.
Okay,
but
lots of positive feedback. Thank
awesome.
You so much
Thanks,
for the
guys.
explanation. So
I'll have a look at the comments afterwards.
That's really wonderful.
Awesome. So if you're new to the channel, do please consider subscribing. Hopefully you found this video really helpful. And if you know someone else that's got spondylolisthesis or struggling with it, maybe they don't necessarily fully understand it, or you feel like they might be getting worse over time, please do consider sharing this video with them. If you're one of our subscribers, do please stay tuned, because tomorrow we've got the announcement of that giveaway. It should be really, really awesome. So we'll discuss more details on that tomorrow. But with that being said and all that out of the way, if there's nothing else, Lara,
yeah, no, that's everything.
have a great afternoon. We will see you guys tomorrow with another live stream.